So in the previous antenatal clinic that we've seen, we've discussed most purposely three approaches that we need to use. We said we have traditional, we have focused, and we have high risk. Tentatively, we ate four because the WHO revised the focused antenatal care in 2016 and it had some inputs into it. And therefore, we focused on tradition. We've seen about it. We've seen the difference between contact and visit. We've seen something about focused antenatal. Now, today we want to see the approach, the last approach, that is high risk approach. What does it mean? High risk simply means the factors that surrounding the pregnancy that can put a mother and can put a neonate or that can put both mother and the fetus in risk or at risk or in jeopardy. So these objectives we have already looked at them and they are very, very, very key. Why are you doing the antenatal? You want to screen and prevent. You want uh, to anticipate difficulties. You want to treat. You want to ensure healthy birth. You want to uh, prepare for birth. You need to promote understanding between the healthcare workers and you need to and community. Now, when you screen, you can use examination, you can use history taking, you can also look at the most important thing in clinical methods. So these risk factors or the factors surrounding uh, the mother in pregnancy that can bring about normally we have divided them into maternal. We have also from the medical history, we have those that are intra labor and those who which are post labor. So maternal factors is age between 20 and 29 are the best ages of birth. Now below 16 and 30, these are at risk. Then short stature below 150 centimeters high. Then the BMI that is below 20 and above 24. Then reproductive history. Um, when we have two or more miscarriages or we have um, induced abortion, when we have previous stillbirth, when we have previous birth of babies with congenital anomalies, when we have previous preterm labor, previous birth of small for gestational age, when we have a primary gravida, when we have a reproductive history, malpresentation, multiple gestation, when we have antepartum hemorrhage, prolonged labor, third stage of uh, third stage anomaly, such as postpartum hemorrhage, retained placenta, and then you can have ABO, rhesus immunization. Then the medical history. From the medical history, you can have mother who has had pulmonary disease, renal disease, thyroid disease, psychiatric disease, cardiac diseases, and orthopedic diseases. All these are medical components that can jeopardize the pregnancy. And then we have medical disorders such as epilepsy, viral hepatitis, preeclampsia, anemia, infections in pregnancy, and pelvic tumors. For example, epileptic anti-epileptic medications such as phenytoin. If you think of it, it depletes folic acid from the body, the reservoirs. And then you think about vitamin D depletion and then teratogenic effect. Then previous surgery, myomectomy, repair of complete perineal tear, repair of bladder, vaginal fistula, repair of stress incontinence. All these are high risk factors from the history. Then family history, you think those from low socioeconomic history, economic status, they have a tendency to have anemia, preterm labor, and the growth retardation. Then those with affluent, they are obese, then overweight babies. And then there's history of diabetes, hypertension, multiple pregnancies. And then uh, we've spoke about um, factors surrounding um, pregnancy before labor, and they put the mother, the, the fetus who has not been born, into um, jeopardy. But now here you can have um, intra-labor, high risk factors in labor. The mother has never attended an antenatal clinic. It's high risk because you don't have the history, you don't know anything, and he is or she is in labor. And then anemic mother, premature or prolonged rupture of membranes, amnionitis, meconium silica, all these they jeopardize the mother during labor. Then you can have multiple pregnancies. You just discover that there's twinning, and then the mother is in labor. Then rupture of uterus, patient having induced or induction or accelerated labor is called precipitate labor, difficult process of bridge delivery. And then postpartum, after labor, for the for the for the newborn, when you have anemia, hypothermia, then you have a baby below uh, 2.5 kilos or about 4 kilos what risk of hypothermia. The 4 kilo is at risk of hypoglycemia. And then the Apica score below 7. And then there's convulsion of the baby or the mother. The baby can develop respiratory distress, the fetal infection, persistent cyanosis, jaundice, hemorrhage. And then we have management of these. You just need to stratify the health facility. There's need for training. There is need for emergency or elective cesarean section. You can need to reduce labor in some cases. And then you need to do advocacy for what we've said above. So all these, bye bye until we meet again.